Webinar is going to cover very briefly diabetes mellitus. We're going to show the difference between types 1 and types 2 diabetes mellitus, as well as discussing a little bit about gestational diabetes. Now, chiropractors are going to be treating diabetics, especially if they have a practice that's going to be addressing a lot of neuropathies, because diabetics have a much greater incidence of neuropathies. Diabetes mellitus is an extremely prevalent condition in the United States. And as of 2011, there's 25.8 million people in the United States with diabetes. That corresponds to about a little over 8% of the population. So the chances of a diabetic coming into a chiropractor's office is extremely high. There's a lot of conditions that are associated with diabetics that a chiropractor definitively is going to be addressing, such as neuropathies, carpal tunnel syndrome, shoulder issues, joint mobility issues, stiff hand syndrome. So the chiropractor should have a general knowledge of diabetes. Now, I use that term, if I use the term just diabetes, I am pretty much referring to diabetes mellitus, even though you already know that there's a diabetes insipidus. But since diabetes mellitus is hands down much more common, if someone just says diabetes, you automatically assume that we're referring to diabetes mellitus. Now, before we kind of go on about the differences between type 1 and type 2 diabetes, the complications of diabetes mellitus are huge. If diabetes is not managed properly, they don't control their blood sugar properly, they have a huge risk of heart disease, stroke, high blood pressure, blindness, kidney disease, neuropathies, amputations, and death. And as of 2013, it has cost the United States over $245 billion in the management and treatment of people with diabetes. Now, diabetes can be managed very well by diet and exercise and a number of different things. Now, when we talk about type 1 diabetes mellitus, those individuals still need to take insulin as an insulin replacement, but they also need to make sure they're eating properly and exercising properly. So this was something that you'll be discussing in lab, is first, if someone goes and has some blood work done. Fasting blood glucose, these are the ranges. You might get slight differences depending on what lab you pick up. But generally, if you have a fasting blood work done, your glucose levels should be less than 100 milligrams per deciliter. But it's anywhere between 110 and 126 milligrams per deciliter. It indicates you have impaired blood glucose, which would want a physician to want to have a glucose tolerance test to just double check to make sure if it's truly impaired or the person has diabetes. If it's greater or equal to 126 milligrams per deciliter, you have diabetes. So they need to be able to address that. Now, if you've ever had a glucose tolerance test, you go into the doctor's office, you drink a particular liquid, it's very, very sweet, and what they'll do is they'll take blood samples so many hours after you've consumed the glucose, generally about 2 hours. Now, these are values that if they come in 2 hours after you consume the glucose, what's considered normal, what's considered not. Now remember, you just consumed a whole mess of glucose, blood sugar levels are going to go up, but that should be triggering the release of insulin to start bringing it back down. Well, if you've got normal glucose tolerance, 2 hours after you ingest that glucose load, it should be less than 140 milligrams per deciliter, because that indicates the insulin is being released and it's starting to work, and it's going to bring the blood sugar levels down. If it's between 140 to 200 milligrams per deciliter, it indicates you have impaired glucose tolerance. If it's greater than 200 milligrams per deciliter, you have diabetes. Now, if you have impaired glucose tolerance, they're going to start making sure that you're aware that your chances of having overt diabetes are very high, that you need to really start watching your diet, watching your weight, watching your alcohol consumption, a number of different things, because your incidence of developing overt diabetes is very high. Now, there's a difference between type 1 and type 2 diabetes mellitus. The abbreviation here, this IDDM, refers to insulin-dependent diabetes mellitus. Over here, the type 2 is referred to as non-insulin dependent diabetes mellitus. Old school, a long time ago, they used to talk about juvenile onset diabetes and adult onset. It can no longer be used. It should not be used, because although in the past, most often type 1 is you develop that as a child, juvenile onset. Type 2 is most often clinically develops, the onset is usually older individuals, usually greater than 30 years of age. But there are people who've developed type 1 as adults. There are people who develop type 2 as children. So here I've just listed generally the onset, but it's really, I wouldn't even look at that. So it's you can't go by the age of onset. Most often people with type 1 are normal weight individuals. Type 2 is most oftenly associated with obese individuals. But again, not always. I've seen people who had type 2 that look perfectly normal weight. Type 1, their blood insulin levels are low or absent, depending on what stage they are in it. Because what happens is they have particular antibodies that are targeting the beta cells. So what is associated with this destruction of the beta cells in the islets, which destroy the subject's ability to make insulin. In the course of the destruction, the insulin levels they're still going to be producing insulin until all the beta cells are destroyed. So it could be low blood insulin or absent blood insulin. Now, type 2 diabetics, their insulin levels are either high or normal. Their problem is they're not destroying the beta cells. They make insulin. It's just that the receptors to insulin are not functioning properly. So they refer to it as more of an insulin resistance. So the term is relative insulin deficiency, because for the same amount of insulin between them and a normal person, the normal person is going to have a response. But the same level of insulin, they're not going to have nearly the amount of response. So they're going to have higher levels of insulin in order to have the same response as a type 1 diabetic. So it's more of an insulin deficiency or insulin resistance. Type 1, it's an autoimmune condition. They destroy the beta cells. Severe insulin deficiency. The type 1 will have to be managed with insulin. So they will have to receive insulin. Type 2, not necessarily. Some will receive insulin, but some don't. Lots of times they manage this one with diet. Now, gestational diabetes, this is where a woman who does not have diabetes, she's never been diagnosed with diabetes, that during pregnancy, her blood glucose levels are elevated. It is believed to be due to a problem with the insulin receptor during pregnancy as a result of some gestational factor, some factor associated with pregnancy that affects the insulin receptor. Now, the cutoff for diabetes in a pregnant woman are less. So generally, I believe, fasting blood glucose levels in a pregnant woman If they're over 110 milligrams per deciliter, that indicates gestational diabetes. Often the woman will not have any symptoms. It's usually picked up during screening. So pregnant women are always being monitored for blood pressure. They're always going to be monitored for the blood glucose levels. The gestational diabetes often starts to appear in the third trimester of pregnancy. So how will they treat it? Or we should ask first is, why should they treat it? Well, babies born to women, or I should say, if they're born to the women with diabetes, if that diabetes is not controlled, the babies, if they are delivered, are going to tend to have an increased risk of being large for their gestational age, so it could lead to delivery complications. Babies can have low blood sugar. They can be jaundiced. They have seizures. Stillbirth, so that baby will be delivered but not alive. The children later in life have a much increased risk of developing childhood obesity and type 2 diabetes mellitus. Now, on the mothers, if the mothers with gestational diabetes are not managing or treating that diabetes, they have an increased risk of developing type 2 diabetes mellitus, and in some cases type 1, overt type 1 diabetes mellitus later in life. They have increased risk of developing preeclampsia during the pregnancy, which is extremely dangerous to the child and as well as the mother. And they have an increased risk of having to have a C-section, so that kind of leads back to those delivery complications. And no one wants to have a C-section if they can help it. So what's the treatment? Well, they manage it with diet and exercise, and in some instances maybe medications, but often they're going to watch. The mother's going to have to be very watchful of what she eats to try to control her blood sugar levels during pregnancy. So this is going to be the end of this very short webinar for diabetes.